All right. So, as I said, I'm going to just bring up a few illustrative cases. We'll pick on the panelists a little bit as to how they're going to manage these. So the first case is a 36-year-old male. He had a thyroid nodule that was discovered by his PCP. He did not have any compressive symptoms of any sort. There was no history of radiation exposure, no family history of thyroid malignancy, no personal history of malignancy as well. On clinical exam, he had a 3-centimeter palpable left-sided thyroid nodule, which was firm. There was no palpable lymphadenopathy. His PCP actually sent him for an ultrasound. Actually, he came with a fine needle aspiration result and was in my office. So I'll just show the ultrasound images. And as you can see here, this is a left-sided thyroid nodule located, involving most of the mid-pole and the inferior pole. It's a mixed echogenicity, predominantly isoechoic with some hypoechoic areas. The vascularity, there did not appear to be significantly increased vascularity on this nodule. The right lobe was completely normal. His TSH was 2.4, and the report that he came with was that it was a follicular neoplasm, and it was Bethesda category 4. So at this point, would anybody want any additional lab work on the panel? Volunteers?
Nope.
Okay. So what are our options at this point? Who would just repeat the ultrasound in 6 months? Nobody. Okay. Who would take this patient right to surgery or send the patient to surgery? And if so, what would you do? Hemithyroidectomy, total thyroidectomy? Julianne?
I would, with no contralateral nodularity, I would do an ipsilateral thyroid lobectomy, and I would not do a frozen section or touch bone.
Okay.
What did the ultrasound show on the other side?
Normal.
Normal, yeah. So you have a young patient. One of the things I always like to do is my own ultrasounds, because the images, unless they're dynamic, you really lose a lot of information. So, you know, the contour looked smooth. You can't really tell microcalcifications on a still image. So if you have a dynamic image, you can get a sense if there were microcalcifications. I'm assuming there were not.
Nope.
I did not find that particularly hypervascular, and the contour is smooth. So you have a low-risk ultrasound, 3-centimeter, although when I looked at your measurements, it looked more like 4 to me, but are we saying it's 3?
Yeah. Well, no, it's actually, it was on ultrasound was larger on the vertical dimension. So the clinical examination clearly was not as accurate because you're more measuring the
So
the
you have
width.
3 centimeters that's on clinical, but the actual measurement is more like 4, which makes what I'm going to suggest maybe just a little dicier. So you have a young patient whose chances, even if they have malignancy, of doing well are overwhelming. And I think this is a perfect example of a case where you would consider a gene expression classifier. And the reason for that is that if we look back on the June 2012 New England Journal of Medicine paper, where you have gold standard histology compared to gene expression classifier, you're going to have, for a follicular neoplasm, a 94% negative predictive value. If you do a fine needle aspiration cytology and that were benign rather than follicular neoplasm, you're also looking at a 94 to 95% negative predictive value. So you have equivalence, and if you look at your 2013 NCCN guidelines, it suggests that if you have a genetic test that is equivalent to a benign fine needle aspiration cytology, it is very reasonable to do that test and observe that patient as an option rather than an operation. And I think that you need to have a good informed consent with that patient. I think it's not unreasonable to state that this is relatively new data, but it's very solid data. And so you need to get the sense of the patient's opinion on it. Now, the one proviso I'd have here is that it is 4 centimeters, and one could argue that there could be geographic miss on a needle biopsy. And so when you're going to do a gene expression classifier, you're looking at 2 passes, and that goes in a messenger RNA compatible solution and sent off to Veracyte lab. So one could argue that maybe you could have a geographic miss, but on the other hand, he's not having compressive symptoms. What does he do for a living?
This gentleman is an office worker. I forgot exactly
An office
what he
worker, you know, that's maybe not what you're saying, a professional voice user. You know, that's a dependent factor. What if he's a choir director in a high school? You know, and you get in there and you have your 1% vocal fold immobility on this patient, you've ruined his life. You know, so I think that's a factor you need to be looking at as well. So this is what I would do if this was my patient, and if I was 36 years old, this is what I'd want for my neck.
So Julianne, what do you tell the patient with the 4 centimeter male solitary nodule? What do you tell him with the follicular neoplasm? What his risk of cancer is at that point?
So I think it's important always to be able to not only be familiar with population level data, but also to know your unique institutional data. And so I would say at Duke University, if we have a cytologic interpretation of a follicular neoplasm, the likelihood of this being a cancer is probably around 30% based on our review of histologic and cytologic correlation. And actually, in this young age group, it would potentially be a follicular variant of papillary thyroid cancer that we would find actually more often than a follicular carcinoma, and these are some emerging data coming out. So that is what I would quote him. I absolutely agree with Dr. Witt. I think that these conversations have to be sophisticated and extensive, discussing the risks and benefits of different approaches. And I think, if we were going to pursue either the gene expression classifier or other molecular testing, since it wasn't done on the first pass, that would have to be repeated. And there is always some question about how long should I wait before I repeat the biopsy to accompany it with a molecular test. I would discuss age and the continued need for surveillance, the potential increase in size of this nodule. The fact that he is a man certainly puts him at slightly increased risk of this being a cancer. And I think all of that has to be traded off against the risks of surgery. Of course, the benefit of surgery is I do think that is the one way we can definitively resolve whether this is a cancer or benign process.
Well, so I always have this, I promise you I'm going to give you time to, we're going to do Q&A after this stuff. Yeah. So I always have this discussion with the patients, their options, surgery versus repeat FNA and the possibility of the gene expression classifier. He actually did not want surgery at first, so then we went the route of the gene expression classifier. In a little bit, I'm going to have one of the panelists come and just sort of talk a little bit about a little more details and evidence-based data on this gene expression classifier test. So we'll leave that for that. So his test comes back suspicious. So Adele, how often do you think that these follicular neoplasms, when they get sent for GEC, come back suspicious? So if the histology is follicular neoplasm,
Right.
or suspicious for follicular neoplasm,
Right.
and it gets sent for GEC, how often, what percentage of those do you think generally come back
Well,
suspicious?
I don't know. I have not used the GAC in evaluating these tumors, and I don't know how people will use the EGC to determine if it's suspicious or definitive cancer. I have no idea, and I have not yet to see prospective data to show that every time that a decision was made based on the GEC and FNA, the biology confirmed that. In an absence of these data and a convincing data or determine beyond the shadow of the doubt that that patient will develop cancer, and therefore you need total thyroidectomy, or otherwise I would rest on histology. And in a histology, back to the histology, it's also limited. If we call adenoma or indeterminate, we don't know what, or encapsulated follicular lesion, encapsulated follicular carcinoma, atypical follicular neoplasm. All of these are gray zone that we really don't know. If we follow the patient for 10 or 15 years, some may develop, some may not develop anything. So we still back into it, and the best way is to just make decision based on the patient, their age, functions, and all of this, and decide on surgery. That's what I do.
If you look at the Veracyte publications, it's about half of their results come out suspicious. And it's important to know what that means. So if you're doing molecular alteration testing and you have, for example, a BRAF, which is a point mutation, then you have a 99.4% chance that that is cancer, papillary thyroid cancer. It has got a very, very high positive predictive value. That's the power of that test. The power of this test is the negative predictive value. The positive predictive value is very low for the gene expression classifier. So it's anywhere between 37 and 50% that suspicious will actually be a thyroid cancer. So that also may change what you're going to do. So if you have a BRAF 3 centimeter thyroid nodule that's positive, you are going to potentially want to do a therapeutic operation up front that's a total thyroidectomy, depending on your philosophy on lobectomy versus total. But if you have a 3 centimeter thyroid nodule that's suspicious, you only have a 40% chance that actually is malignant. And so you may wish to start out, it would be with a lobectomy. So it's a difference in the power of what each test can do. So it's very important to know what you're getting out of each test.
Right.
Let me make a comment on the BRAF. The BRAF, it's in papillary thyroid carcinoma, and there is no problems by cytology or by histology to do that test, to get, determine the diagnosis. Diagnosis is made easily by $2, FNA or an HNA. The question is the GEC, it's not the specific genetic mutation. It's how you're going to do that panel and determine beyond the shadow of the doubt that this biologically malignant. That's a question.
Okay, so in the interest of time, I'm going to move on. So we did a hemithyroidectomy, and it was benign. So